Let me first thank Dr. Akash, Parag, Dishank, Sushil, Kamaldeep, and the entire local team of Baroda for excellent organization of this annual meeting of Gujarat chapter. I'm very much thankful to them. We should all give a big round of applause to the local team for excellent arrangements. So this is an industry sponsored symposium, and this is a talk which is sponsored by Zydus Pharma. It is related to role of Empagliflozin in cardiorenal metabolic continuum. So we all know that with our better understanding of pathophysiology of type 2 diabetes, from 2 defects to 8 defects, we now understand the role of kidneys in maintaining sugars in the normal range in human beings, and therefore there is a definite role of variety of agents which target these different pathophysiological defects, and lot of drugs are now in our armamentarium to treat type 2 diabetes. Also, our understanding is improved from the era before rosiglitazone, where we were not thinking about anything related to cardiovascular disease. Then came the rosiglitazone saga, when the anti-diabetic drugs were happened to cause cardiovascular toxicity. Then there was an era of DPP-4 inhibitors, where the cardio safe for neutrality was required to be proven for every drug before being launched for management of type 2 diabetes, and those cardiovascular outcome trials have given us now newer agents which not only provide cardiac protection but also renal protection. So now we are in the era of cardio-renoprotective therapies, and probably in near future we will be in the era of not only cardio-renoprotective but also weight loss or weight protection strategies for management of all these chronic care disorders. This is the roadmap for SGLT2 evidence. The last release trial related to SGLT2 is role of empagliflozin in CKD, that is EMPA-Kidney trial. So I will be touching upon empagliflozin. We all are hearing a lot of bombardment related to this molecule in our clinics, with the patent being off for the main molecule by the patented pharma multinational, but now almost all companies, they are having this molecule, and it has been approved for use not only in type 2 diabetes for glucose control and cardiorenal protection, but it is also approved for use in heart failure irrespective of the presence or absence of diabetes, and chronic kidney disease irrespective of the presence or absence of diabetes by US FDA. So I will just start with the mechanism of action. We all know that SGLT2, which is an enzyme in the proximal convoluted tubule, which contributes to more than 90% reabsorption of glucose from the renal tubules, and by blocking these drugs, they provide glycosuria, they lower plasma glucose, and this is independent of their impact on either insulin resistance or insulin secretion from the pancreas, and thereby they reduce HbA1c, they reduce glucose toxicity, and as we all know, glucose is a calorie dense substance. It will result in calorie loss, weight loss, and that will result in loss of fat, particularly from the ectopic areas of the body, mainly abdomen, fat from the liver, fat from the pancreas, and also epicardial fat will go down when we use SGLT2 inhibitors. There will be osmotic diuresis resulting in reduction in plasma volume, that will translate into reduction in blood pressure, cardiac preload. Also there will be natriuresis, which will alter tubuloglomerular feedback, that will reduce glomerular pressure, glomerular hyperfiltration, it will reduce arterial pressure and improves cardiac afterload. So this is in a nutshell how SGLT2 inhibitors, they provide multiple benefits. They are having good glycemic efficacy, HbA1c reduction to the tune of 1 to 1.5%, fasting, PPG both go down. If you see the average glucose excretion with empagliflozin 10 milligram, it is around 65 grams, and with 25 milligram, it is around 78 grams per day. This is the data from our own country, although very trials with multiple limitations, still they can say that patients on 3 drugs, you add empagliflozin or dapagliflozin or rimogliflozin, you can get a good HbA1c reduction. This is another study Indian where the HbA1c reduction to the tune of 1.5 was observed when EMPA was added on top of other therapies. If we increase empagliflozin 10 milligram to 25 milligram, whether there will be any further benefit in glucose, body weight and other things. So this is one study, 52 subjects with type 2 diabetes, inadequate glucose control. EMPA was increased from 10 to 25 milligram. If you see fasting decreased by 12.7, HbA1c by 0.13, body weight by around 0.6 kg, BMI 0.2 kg per meter square, TG by 22.1 milligram and GGT by 6.6 units, and also hematocrit was significantly increased by 0.9 gram, 9% after 3 months. So definitely increasing from 10 to 25, there will be further benefit in glucose control as well as an additional weight loss to the tune of 1 kg. This is the analysis, EMPA-REG outcome, same analysis. Patients who are on empagliflozin, the chances of requiring insulin, new initiation of insulin is 54% less risk. Same way, the patients who are on insulin and you put them on an SGLT2 inhibitor, there is a less requirement of increase in insulin dose. So more than 20% increase in dose, 57% risk reduction. So they definitely improve glucose control across the spectrum of diabetes, be it new onset with metformin or even at the fag end when the patients are on insulin therapy. You can use this molecule, you can curtail down the use of insulin. At the same time they will provide pleiotropic benefits also. So in nutshell, these are the metabolic benefits: reduction in plasma glucose, glucotoxicity, body weight, triglyceride and small dense LDL will go down, the large beyond LDL will increase, improvement of insulin sensitivity, plasma uric acid will go down, there will be a switch of energy use from glucose to fatty acids, so fuel efficiency will improve, reduction of lipotoxicity will also take place. As far as weight loss is concerned, this is EMPA-REG data as compared to glimepiride. Empagliflozin 5 kg weight loss at 114 weeks. There was more than 90% weight loss was due to fat mass loss, visceral adipose tissue went down, waist circumference decreased by around 4 centimeter. But we all know that now we understand that weight loss, if it occurs with any kind, SGLT2, GLP-1, lifestyle, bariatric, about 1/3 loss, it occurs in fat-free mass. So you have to be careful when you are using these agents, particularly in people who are having low muscle mass or sarcopenia. You have to tell them about good protein intake as well as muscle strengthening exercises to maintain their muscle mass. However, the EMPA elderly trial, which was published recently from Japan in very elderly people, 75, 80 years old, they were given empagliflozin and there was no evidence to say that empagliflozin was associated with increased risk of muscle mass loss or muscle strength loss. So you have to be reassured that it does not increase the risk of sarcopenia even in elderly people. What about MAFLD? This is ELIPT study from Delhi where patients on empagliflozin as compared to control, there was a reduction in hepatic fat content, and there is some data to support that there is some histological improvement, but currently it is no SGLT2 is approved for use in MASLD. You can use at a part of type 2 diabetes management, further pleiotropic benefit of reducing hepatic fat also. There is EMPA-REG data which also says that if you use empagliflozin, then there is a decrease in risk of new onset obstructive sleep apnea by almost 52%. So this is another pleiotropic benefit of empagliflozin if you use it in type 2 diabetes obese patients. Apart from metabolic, SGLT2 inhibitors, they also provide hemodynamic effects. And these are in the form of natriuresis, which results in improvement of salt sensitive hypertension, reduction of blood pressure, reduction of or improvement of sympathetic nerve hyperactivity, reduction of volume overload, interaction with RAS system, there is reduction of cardiovascular remodeling and modulation of the tumoroglomerular feedback system because it acts on the glomerulus also and decreases the intraglomerular pressure. If we see the blood pressure, these are the multiple mechanisms by which SGLT2 they contribute to reduction in blood pressure, both systolic and diastolic. This is again EMPA-REG outcome analysis related to blood pressure reduction, Empagliflozin. They have also tried to find out whether it was dependent on baseline antihypertensive medication use, no or one or two, and it is almost similar. This is systolic blood pressure data at week 12 by number of antihypertensive medications. There is a reduction in systolic blood pressure to the tune of 3 to 4, and same is there for diastolic blood pressure. This is data with all three, and this is with home blood pressure monitoring, 24-hour morning, evening, nocturnal, all varieties of whatever method you use for blood pressure estimation or measurement, they are improved with the help of SGLT2 inhibitors. So it can provide you an additional benefit of blood pressure reduction in type 2 diabetic patients with having coexisting hypertension, obesity. However, currently it is not approved as an antihypertensive medication, but you have to keep in mind those patients who are having resistant hypertension, there is data to support that if you give them SGLT2, their chances of improving blood pressure control and reaching targets will improve. We all know that diabetes and heart failure, they go hand in hand. People with diabetes at every age, they are at higher risk of developing heart failure, and at the same time, if they are having heart failure, irrespective of the ejection fraction, they are at higher risk of both CV death as well as heart failure hospitalization. And SGLT2, we all know that now they are the approved treatment in heart failure across the spectrum, be it heart failure with preserved ejection fraction, mid-range ejection fraction or reduced ejection fraction, and these are the variety of mechanisms through which SGLT2 inhibitors, they contribute to better outcomes in people having heart failure, either preserved or reduced ejection fraction. EMPA also has got evidence to support its use in heart failure, both reduce and preserve ejection fraction. These are two trials. I will not go in details of these trials. Emperor reduce, Emperor preserved. Both these trials, the primary composite outcome of heart failure hospitalization or CV death was much better when Empagliflozin was used in this category of patients, whether they were having diabetes or not, either they were having heart failure with preserved ejection fraction or with reduced ejection fraction, and EMPA was used in the dose of 10 milligram and it was beneficial. We all know about, very sorry for this, I think it is not projecting properly, but SGLT2, as far as CKD is concerned, we now know that it is also approved as a renoprotective therapy. Apart from metabolic and hemodynamic, they have got some direct renoprotective effect. They reduce renal fibrosis and inflammation at the level of kidney. And this is EMPA kidney trial, phase 3 randomized double-blind placebo-controlled trial. Here again Empagliflozin was used in the dose of 10 milligram as compared to placebo. People having CKD at risk of kidney disease progression, and primary composite endpoint was CV death or kidney disease progression as defined by this sustained decline in GFR or end-stage kidney disease or renal death. And key secondary outcomes were first occurrence of hospitalization for heart failure, CV death, all-cause mortality or all-cause hospitalization. And they have included two categories of patients. One, patients who are having CKD with normal albumin excretion. So here the eGFR was 20 or more and up to 45, and second group who were having albumin excretion more than 200, and at the same time eGFR either was between 45 to 60 or even 60 to 90. So normal eGFR or stage 2 CKD patients with albuminuria and stage 3 or stage 4 CKD patients without albuminuria, they were included in this trial. So very large proportion of real world clinical practice. If we see from our clinical practice, 13.5% of patients they can be represented as per the EMPA kidney trial. This is US data. So much more representative of real world practice, those kind of trial was the EMPA kidney trial. And if you see the end-stage kidney disease or CV death or end-stage kidney disease or all-cause mortality, everything was improved to the tune of 20 to 33%, and kidney disease progression or cardiovascular death was improved by 8% irrespective of diabetes or no diabetes. And therefore, they concluded that if the eGFR is even 85 and you give them empagliflozin, there is a potential delay in kidney failure by 26 years, and you can avoid this many hemodialysis sessions. As the eGFR goes down, the potential delay in kidney failure also goes down, and the potential benefit as far as hemodialysis sessions are there also goes down. And therefore, it is approved for use in CKD by KDIGO. This is the long-term data of EMPA kidney. After the trial, the empagliflozin was discontinued, and still the benefits were there even at the end of second year. So they can provide good renal protection to patients who are having renal disease, diabetic kidney disease. So can we compare EMPA with other drugs? This is, we all know EMPA-REG, CANVAS and DECLARE. EMPA-REG was the trial where almost 100% of patients, they were having established atherosclerotic cardiovascular disease, and this is the only molecule which has provided cardiovascular death and all-cause mortality benefit. No other molecule has given this benefit. All other molecules, they are giving hospitalization for heart failure or CV death benefit, or heart failure hospitalization or renal composite endpoint. However, we can say that it is because of the overall trial population in which the drug was studied. Ultimately, it is a class effect. There are few data where they have compared DAPA with AMPA. This is Danish nationwide cohort study, and they have concluded that treatment with DAPA was associated with a similar rate of major adverse cardiovascular outcomes compared with empagliflozin, and this is a class effect. At the same time, this is another article from JAPA where they have tried to compare EMPA with DAPA in patients with heart failure, and this is from the US cohort study, and they concluded that empagliflozin patients were less likely to experience the composite of all-cause mortality or hospitalization compared with those who are initiated on dapagliflozin. 10% reduction, hospitalization for heart failure only 10% reduction. All-cause mortality did not differ between the two groups. So, EMPA was better as compared to DAPA in patients with heart failure. Same has been written in this article which is published in 2023. Again, cohort study. Among patients with CKD, EMPA provides a better monetary value for preventing the composite renal and cardiovascular events in diabetic patients, while dapagliflozin has a better value for non-diabetic patients. So still both have got value, but EMPA has got better evidence in type 2 diabetes. So to conclude, I will say, SGLT2 inhibitors, they have changed the way we practice type 2 diabetes management in our clinics. Empagliflozin has shown the benefits not only in diabetes but across the spectrum in heart failure as well as in CKD, and pleiotropic benefits of empagliflozin makes it a drug of choice in multiple scenarios. Thank you very much.